Pleasure to introduce our speaker, Dr. Pete Koval. Dr. Koval received his PharmD degree from Campbell University in May of 1994. Following graduation, he completed a PGY1 residency in Greensboro, North Carolina. He then completed a second year of primary care residency training in St. Louis, Missouri. His current title is Associate Professor of Clinical Education at the University of North Carolina Eshelman School of Pharmacy. His clinical practice site since 1996 is the Cone Health Family Medicine Clinic and Physician Residency Training Program. Dr. Koval has facilitated tobacco cessation efforts throughout his 28-year career at Cone Health Family Medicine. And Dr. Koval, it is absolutely a pleasure to have you with us tonight. Dr. Koval has been with us before, and so it is a pleasure having him. And with that, I'm going to turn the podium over to you now.
Awesome, and thank you all for joining this evening. I will get started. All right, I have no disclosures this evening, nothing to share. I don't get paid to do any of this on the side. My objectives are really straightforward and hopefully what you need. The idea of making sure you're comfortable with all the products we have in the marketplace, and then hopefully the ability to more effectively initiate and adapt therapy in patients that you may be collaborating, working with. As you all know, there is a statewide protocol now in place, and I think that part of this NRT that really enables us to do as pharmacists, management, and hopefully get paid. Pharmacists can bill and get paid for this, which is just wonderful. So I think you're all aware of this, and we'll talk more details about that as we go, but that's part of the intro. Here's my outline. I will give a little background. I'll go through all the therapies, and then in the patient care tools section, hopefully that's where we'll talk a little bit more of some things that really can make this more useful for you in practice. So we'll start with some background. So I'm going to go over some of the things in the economic box, some products, a couple pieces of just evidence, and how to diagnose officially. So let's just get started. So on this slide, I'll throw out a number. And the number I want you guys to really take home, and over the last couple years, we've all sort of gotten, oh, there's lots of people dying from COVID. And in any calendar year, you can look this up. In any calendar year, pick 2020, pick 2021, pick 2022. Every year, the number of deaths is less than the number you see on this screen. So there are more tobacco/nicotine smoking-related deaths in the U.S. every year. Yet there was a pandemic, and I think the idea, hopefully that will just sort of get your attention really fast tonight to say, this is one of the most cost-effective things you can do for healthcare, and it's really, quite honestly, my reason for my passion is this is something that pharmacists can help with, and we can help decrease healthcare costs. I think all of us recognize what you're going to say to a patient. Why should you quit smoking? Lung disease, heart disease, cancer. When you think about those therapies, the therapies we have to spend money, and they tend to land in folks who are on Medicare. Lung disease, heart disease, cancer. Yeah, and who pays for Medicare? That would be yes, everyone with a paycheck. So the concept here of, is this worth our time? And absolutely the answer is yes. All right, so if we can get paid to do some of this and really sort of decrease healthcare costs, by doing this, we get this sort of double benefit. Some of the take-home points on this, I'm pretty sure you guys have heard something like this before, that smokers die 10 years younger than non-smokers. And I think this bottom bullet point, that for everyone who dies, there's 30 people out there who have a smoking-related illness that's serious. And I do think the part is saying we all recognize that as being real. I've updated the costs. So just straight Medicaid. If there's nothing else you take home, you say $1 billion, yeah, with a B, $1 billion a year. Yeah. So name me a disease state that's costing us $1 billion in North Carolina. Good luck. This is one of the ones that basically, when you think, drives costs, and it is one of the reasons that Medicaid is very interested in anybody, including pharmacists, trying to help decrease, if you will, smoking rates in this state. This slide's here for me to remind you that the FDA regulates all tobacco products. So this little pictogram there, the pictures are in the order of what you see listed on the right. So just to remind you that, yes, my favorite's the last one, and anything else in the future. So if you want to put nicotine in water and call it nicotine water, we'll regulate that. Just anything it is, yes, the FDA is going to regulate all tobacco products. This is the update on numbers. So for those of you who don't know much about my ancient history, I grew up in Pennsylvania, and I grew up just outside of Pittsburgh, which is where the two rivers come together to make a third. And that third river is the Ohio River. And you guys can just on this map just appreciate it. There's a wavy line that goes between Ohio and West Virginia, onward between Ohio and Kentucky, and that joins, if you will, the lower Mississippi. So if you count sort of states here and you sort of count them all up and you say, hey, look, there's 4 states along the Ohio, and then there's 5 more states along the lower Mississippi, and then you got Alaska. You got 10 states that are not North Carolina. So one of the take-home points is that North Carolina is not one of the top 10 states, even though you think of us as a tobacco state, with respect to current adult smokers. And our number, based on this website, is around 14 and change. Just a little above the US average, which is maybe news to you that we're doing better than many states, and specifically those states in the Midwest and, if you will, the Deep South. This slide is meant to sort of remind you that there are certain subgroups of our population that have higher prevalence of smoking. And the driver that I want to sort of look at, and I think you all recognize, some of this is more, some of this is less, but which one of these is really the biggest driver? And I think I'll just show you on the next slide that my opinion on this is definitely folks with mental illness and addictive substance use disorder. So you think about my substance use disorder folks and my mental illness folks, and you read this, and obviously I've colored something on this slide for you, and that is to say they smoke nearly half of the cigarettes. So when you think about, I'll go back a slide here, you think about this group, and you say, oh, who's smoking all the cigarettes? Half of them being consumed by folks with mental illness or substance use disorder. When we think about that, you start saying, what is that? And you look at bullet point 2, you say 75% of all the patients with dependence disorder have comorbid tobacco use disorder. Yeah, that's a big population. When we think about this sort of subgroup, I think it's probably important to recognize that this is a subgroup that may be a little harder to work with for a variety of reasons. It's not to say that it's not worth doing, but just to sort of say it might be a little more difficult to engage, interact, work with them, and make progress. But absolutely, we just have to appreciate these are some of the folks who still make up our smoking cohort of citizens. One point I'll pull out of the 2020 Surgeon General report is that 90% of tobacco users nationwide started before age 18. So I always make that point to say, this is not necessarily a disease state that you say, oh, let me talk to my 50, 60, 70, 80-year-olds. Yes, they're the ones manifesting, if you will, conditions that are detrimental to their health, if you will, the long-term sequelae of smoking. But when you think about what age they started, it is very common to talk to folks who started before age 20. Very common for folks in their early teens. So just be thoughtful that, we can talk to folks, really almost any adult, and ask them, what are your thoughts on quitting? And I'll come back to counseling in a little bit, but that really is an important take-home point. Is let's not wait till they're getting their COPD inhaler. Let's not wait until they get their oncology diagnosis. Let's not wait till they've had a cardiovascular event. The concept here, let's try to get them to quit before some of those complications occur. All right. Another sort of slide coming out of the Surgeon General report that I've colored on here for you. And you say, really? I'm going to start with the thing at the bottom. 2/3 of cigarette smokers who tried to quit during the past year did not use evidence-based therapy. When I read that, I was like, well, what are they using? Well, very simply, when you read the fine print and you read the rest of it, a lot of folks think that they can do this cold turkey. They can do this without help. And that is very much what is in this bucket, if you will, of what people are trying. They just think that they don't want to try another drug. They can do this without. And I think that's really important that 2/3 of the folks who are trying, quite honestly, are trying something that is not evidence-based, meaning the therapies that we know to work. One of the challenges in the second bullet point here is 4 out of every 9 adult smokers who comes across a health professional during the past year, and yeah, that would include pharmacists, didn't receive any advice. We can sort of say, hey, I don't have time, but remember, this is one of the most cost-effective things you can do for health. So we think about that very first bullet point, 3 out of every 5 adults who've ever smoked quit. So there are a lot of folks out there who are successfully quit. They've tried in the past, and they're sort of, if you will, former smokers. And I do think we need to recognize that that is really important, that people can quit this disease, and they are successful when you look at a stat like that. So just be thoughtful of all of these key points of the background. In transitioning through the diagnosis, then, this is going to get just sort of in the weeds really briefly, and I don't want you to do anything other than say this is in the slide so you can look at it later. You can categorize people with, if you will, levels of severity of use disorder. All right, so mild, moderate, severe tobacco use disorder. There are 11 sort of pieces of this. All right, so on this slide, I have the first 7 of the 11. So you start thinking like, oh, they've had cravings or urge to use tobacco. That's one of the ones on this list. I'll flip to the next slide just so you can see the entire list here in a sec. But when you think about this 7 of 11, where we're going is you're going to count these, and the more they have, you got it, the higher they're going to be on that rating scale, mild, moderate, severe. So the mild person is only going to have a few. If you will, the moderate's going to have a few more, and the severe is going to have even more yet. So I'll show you the cut point in a second, but this is the first 7. 8 through 11 are on this slide. So the idea of, do you have withdrawal? Do you have tolerance? They're on this slide, and you say, oh, okay. In physically harmful situation settings, for example, smoking in bed. Yeah, you check that box, you just check one of them. So here's the summary. If you add up and you look at all those 11 bullet points and you say, I've only got 2 or 3 of those, then we might label someone as mild. If you're 6 or more, then you're going to sort of be severe. And that's really sort of a formal way to make this diagnosis. This is a tool. The Fagerstrom test has been around a very long time. You can see the date on this. The Fagerstrom nicotine dependence scale is a 6-question test that you can. It's 10 points total. So you've added up and you say, oh, okay. Now, 2 of those questions have 3 points. Let's talk about the first one. How soon after you wake up do you smoke your first cigarette? I think all of us who find someone who's pretty addicted to nicotine has a half-life that overnight, they're probably going to wake up in a bit of withdrawal. So what are they going to do? They're going to look for their cigarettes, and they're going to smoke pretty soon after waking up if they are more addicted. So you think about that and you say, all right, within 5 minutes, they get more points. Let's go to the 4th question. How many cigarettes a day do you smoke? For those of you in the audience say don't know how many cigarettes are in a pack, the number is 20. So if they're more than a pack and a half a day smoker, let's call them a 2-pack a day smoker. So they're smoking 40 cigarettes. That would get them 3 points. When you think about those questions, there are some follow-ups here. So let me just sort of have you look at this. Now, the first question, I'm going to go back and I'm going to say, all right, how soon after you wake up do you smoke your first cigarette? They say, oh, yeah, almost immediately before my feet hit the floor. My follow-up question for you to find, I hope, helpful to you would be, do you ever smoke in the middle of the night? Do you ever wake up in the middle of the night to smoke? Why is that important? We don't want to recommend nicotine gum or lozenge for someone who's waking up in the middle of the night to smoke. In a very, very quick and dirty way to say, do you need a long-term prolonged administration tool like a patch? Yes. One of the things you would need to know, are they waking up in the middle of the night to smoke? If they're waking up multiple times, patch is going to be part of your therapeutic plan typically. How about the 4th question? How many cigarettes a day do you smoke? My follow-up there is of what brand? So let's say someone tells me I smoke and something, it's a Virginia Slim Silver. Okay, if you don't know much about cigarettes, that's okay. You can sort of figure this out in time. You can look up brands. You can say, oh, I got it. Nicotine content varies. Various brands have a little bit different. And the idea, the colors on those packs can give you some hints. So in this, what brand do you smoke? Let's act like Misty Slims has 0.5 milligrams of nicotine per cigarette, and someone's smoking 10 of those a day. Well, that's not a lot, so they didn't get a lot of points. But then you say, oh, it's only 0.5. So what's 0.5 times 10? Who's going to recommend 21 milligram patch for someone intaking 5 milligrams a day? Exactly. The idea here that you don't want to just reflexively, oh, step 1, you must start. No. No, you don't always start with step one. You try to match what their intake is. So if they're smoking half a pack a day, maybe make an adjustment. Be thoughtful that their brand may also matter. So if you really get into this, you'll sort of say, "Oh, tell me what brand you smoke." And many times they're going to give you a higher end brand, but not always. And it's that not always you're going to make someone potentially nauseous or have insomnia or just not feel well with their nicotine replacement if we don't adjust for the, if you will, what type of nicotine product they're taking in. All right, my last background slide here. 68% of adult smokers want to stop. Yeah, vast majority. Adult smokers have tried to quit in the last year, more than half, and about 7.5% of people who tried to quit succeed. Yeah, we can help. This is not something that's easy to do, but remember, people are eventually successful. A lot of people who've tried to quit in the past have been successful. So just be thoughtful that all these stats that, how can we help people to be more successful than they would without our help? All right, so that's the first section. I'm going to transition to the medication therapy. I will go sort of quick through this. I think most of this is going to be review, but I'll try to hit highlights of things that you need to know to use the products. So pretty sure you all know nicotine downstream, it affects dopamine, pleasure reward pathway. So there's a release of dopamine. You say, gosh, I feel that. Thank you very much. Whatever you get out of that, the rush from the nicotine, you say, gosh, okay, I feel that. And that happens pretty quick. If you will, what we don't want to do is get into withdrawal. So the concept here of feeling withdrawal from not having enough nicotine, and as you smoke more and more and more, that half-life of nicotine gets shorter and shorter. So you're going to want to sort of think about the folks who are smoking more. Again, they may have withdrawal in the middle of the night. So they may need to smoke in the middle of the night. So those are folks, again, who are smoking more quantity of cigarettes. But again, maybe they sort of have a high intake and their turnover, their metabolism is turning over so quickly that they're going to actually need some type of hit of nicotine somewhere throughout the night. They can't go more than 4, 5, 6 hours. And they'll tell you that. It's been a long time since I slept 8 hours in a night. All right, here's some pictures of products we're about to talk about. I think they hopefully all are relatively known to you. And here's the list. And I think, again, I hope that all of these are known to you. So let's just sort of make a general sort of statement here about nicotine replacement therapy. When we think about products, nicotine is important to just talk pharmacology for just a second. When we think pharmacology of nicotine, you think of dosage forms that have sort of immediate onset. And we'll talk a little bit about the products that we have. And burning nicotine, if you will, creates an absorption effect through the lung, which increases, if you will, speed to effect. So all the therapies we have are going to be slower than burning or lighting or heating nicotine. So that's important to recognize. What we're really doing with all the NRT is giving nicotine in some form. We're really using it to prevent withdrawal. And we're separating, if you will, physical addiction. We're giving some agent, nicotine, that's going to give them the nicotine they need so they're not in physical withdrawal. And we're going to try to help them with their psychological components, which are the triggers that they have, trying to get them to use a nicotine replacement, use something else in those triggering situations. And if you will, deal with all the psychological triggers, and then eventually, if you will, we'll taper down the nicotine and get them off. All nicotine replacement can increase the chance of quitting. And what we talk about here is 2 to 3 times that of placebo. So what you need to know is, well, what's the placebo rate? You remember a couple slides back, I told you that 7.5% of people were successful. Well, a lot of those people may have tried placebo, right? In the trials, it's not far from that. We think in the trials that number being about 10%, and we're going to use the number 6 at 6 months. So at 6 months, maybe 10% of people are successful, completely abstain from smoking. What 2 to 3 times then is, hey, at 6 months, that's going to be 20 to 30%. So bottom line is, this is not a disease state that you're going to be 100% successful. Many of us are really, really, I'll say, attention to detail folks. We really like to have success. We really love winning. But this is not a disease state you're going to win all the time. You're not going to necessarily have complete success and have everyone stay quit forever when you make this intervention. So it's a very humbling disease state because, again, your people will have, if you will, a lower chance of success just because this is very difficult. It's addictive disorder. And it's also important to recognize that they will relapse. So some of these folks will relapse, and that's, again, part of the challenge. Nicotine replacements are not advised in patients immediately post-MI, serious arrhythmias, worsening angina. So I just put that down there at the bottom to sort of remind you there are some situations where we have to think about this, that the cardiologists aren't in love with us throwing nicotine in folks with unstable cardiac conditions. So just be thoughtful. That's really the biggest group. I'll be honest, in the pregnant lactating woman, if it's a compare or contrast of smoking versus using NRT, yeah, NRT is probably safer than going back to smoking. So I think the idea of, or continuing to smoke during pregnancy. So I think you're going to have to just use your best thought process on that group. All right, here's my graphic. And the graphic, again, sort of, everyone find the cigarette. I'm going to put an arrow on it so you can find it. And you all see that that hit of nicotine, this plasma nicotine concentration goes up really fast. Okay, so you feel it really fast in the first few seconds, few minutes. You start saying, okay, so I really get this hit of nicotine in under 10 minutes. And is there anything even close to that? The answer is no. All right, so the Nicotrol or Nicorette oral inhaler down at the very bottom, the nasal spray, you can see their plasma concentrations go up sort of a little bit faster, but gum, lozenge, when we think about gum and lozenge, you can think of them being on the same line, orally absorbed through the lining of the mouth. Then you see this nice gradual line of the patch, right? And the patch, it's going to sort of just be slow onset. So it's a very slow onset time. Again, we're using that to prevent withdrawal. All right, let's get into the patch. There's some details on here. I won't read every line on here, but I usually counsel someone that you can put a patch where a t-shirt goes. That's where it's been studied. If you get the question, can it go somewhere else? I'm going to say on the backside, it's just getting absorbed through the skin. So probably yes, but again, patch, move the site. Again, rotate that site high in their back, on their belly. Just move that around to minimize irritation that is from the adhesive. Okay, so there can be an adhesive reaction. They get a little itching, and again, you can manage that with hydrocortisone cream. You're going to put that patch on in the morning. You're going to wear it typically throughout the entire next 24 hours. When we think about sort of managing this, the very bottom on this slide where we've got insomnia, nightmares, vivid dreams, if those side effects pop up, two things we can do to manage that. One is reduce the dose. Two is stop the patch overnight, if you will, stop it at bedtime. I would argue that I would rather continue at a lower dose for someone who has historically woken up in the middle of the night. I'd rather use the lower dose strategy. If there's never been someone to wake up in the middle of the night, just remember the sort of graphic we had a couple of slides ago, that the patch, when they put it on in the morning, they're going to be deficient. They're not going to have a lot of nicotine in their system in the morning. And that patch is going to take, if you will, 20, 30, 40 minutes to get back into sort of a therapeutic plasma level. So they may wake up feeling a bit jittery, irritable, sort of some withdrawal symptoms. So if they do take it off at night, just warn them that that very first half hour of the day, until that patch kicks in, they're going to have to sort of really focus on trying to avoid smoking or using any nicotine product. This is a slide that you can consider sort of, well, how do I dose these things? And to be honest with you, this is sort of just an algorithm or a sort of a table. There are nuances to this, as I hinted at. Well, what cigarette brand are they using? And in this middle column, what can? So if we're using this for canned tobacco, chew tobacco, for example, snuff. If they're using it for snuff, you know, how many cans in a week? Again, there's different brands, so you have to sort of think a little bit harder. But this is a nice place to start. It's a nice place to start. We want to taper, and one of the things about tapering is I want them to be completely free of use of the nicotine-containing, you know, tobacco product for multiple weeks. I usually say a minimum of 2. And once we get to a minimum of 2 weeks, then you can consider tapering down to the next lowest level or taking the next step. When using combinations, there's no right answer. I'm usually a guy who will leave the gum or lozenge in place and try to taper the patch down, take the patch down again. If I started at 21, I'll go down again to 7. I will then start to pull back, if you will, the PRN nicotines by just sort of 1 piece a week. Meaning if they're using 5 pieces a day, try 4 pieces a day for a week, and then the next week 3 pieces a day for a week, and then, if you will, taper that off. So if you're only using 4, 5, 6 pieces in a month to a month and a half, you can taper that off very slowly, and patients will do quite well with that. Which takes me to gum. I think you all have heard chew and park, chew and park. If you don't want to chew this too fast, you don't want to absorb too much of it. Nicotine is absorbed more readily in a basic environment. So drinking this with coffee, or using this with coffee, using this while you're drinking soda, any acidic beverage, juice, not as good absorption. So the idea of drinking water only while chewing gum, or drinking almost nothing while chewing this, again, you're going to let it absorb through the lining of the mouth. So chew and park, chew and park, chew and park. With respect to irritation, most of it is sort of going to be a reflux, GI irritation. So you may sort of have upset stomach is probably the easy way to say what is the most common side effect of gum or lozenge. There's other listed things on here, but by and large, most people say they feel sort of something either nauseous or feel like they have heartburn or maybe even hiccups, but the idea of some type of esophageal irritation symptom. You can consider in both gum and lozenge sort of ways to pick which one. So the idea of the more they smoke, the more they use. This one is listed as time to first cigarette, which is another way to sort of consider dosing. So if they wake up and they are using a cigarette in 5 minutes and 10 minutes, then maybe you want to recommend the higher strength of gum or lozenge, and that's reasonable. With respect to how many pieces of gum per day, you can see there's limits on here, but to be honest with you, we just sort of want to have it be reasonable to match what their intake is. And again, they're going to have their dwell time to sort of match. So you can have that lozenge, you can suck it the whole way to nothing. You can have that gum and chew it and chew it and chew it so there's nothing left. Or patients may say, I just need to use it for a few minutes, and then they take it out because they got what they needed out of it. And they didn't want to keep using it because they didn't want to get sort of more nauseous out of it. So the idea of every patient's a little different, whether you use it completely or whether they'll just use it for a portion of time, let's say 5 minutes, and then take it out. More common with gum to discard it before all the nicotine's out than the lozenge. Most people will use the lozenge till it's all gone. With respect to the lozenge, the key here is do not chew it up. Okay, again, that's going to create a bolus that you're going to swallow. And again, we want it to absorb gum and lozenge to the lining of the mouth. Same sort of details here, same GI upsets, just suck on it slowly. Remember, there's original sort of lozenges that are the size of a regular cough drop. And you sort of think about this and you say, oh, okay, got it. And again, you can do this with time to first cigarettes. You can sort of titrate those and you say, oh, all right, one lozenge every how many hours? And the idea of stretch it out, stretch it out. You're going to find gum and lozenge are going to be replacements for after meal smoking a lot. And that is when they're tapering down. You say, well, how many are you down to? And they're going to say 3 or 4. I said, can I guess when they are? I'm going to say, I bet you the first one's in the morning and the rest are after meals. How close am I to getting it right? And they look at me like, yep. And the concept there of, it's just a habit. They're very used to smoking after meals. And this becomes, if you will, one of the places or times that they just sort of have gotten used to having a nicotine hit, if you will, after a meal. So nicotine, gum, and lozenge, you get down to 3 or 4 a day. You also almost always have to talk about which meal or what are you going to do next? Which one of these are you going to get rid of next? Remember, there is a mini lozenge which absorbs or gets broken down a little faster in the mouth, a little smaller. So if you have someone who really can't put up with having some in their mouth, they're just sort of a candy chewer, so to speak, the mini lozenge might be for them because very simply it dissolves so much faster that they don't have to concentrate on not chewing it up quite as long because it sort of gets absorbed pretty fast or gets broken down pretty fast. All right, oral inhaler, this is here for completeness. This is one that we don't use quite as much, don't see as much from if you will, prescription. It tends to be non-preferred for insurances that cover it. It is more expensive. It's not any less effective. Some people say, oh, why is it? I wish I could tell you that why this is, sort of lagging behind. I have a good reason, but it just is. There's a cartridge that goes inside. They're going to puff on this. Again, it's absorbed through the lining of the mouth, so it's not a deep inhalation. This is a plastic tube that has a cartridge in it. There is no heat. There is no fire. You have to heat or, if you will, ignite tobacco to get the nicotine to change conformation and get absorbed through the lining of the lungs. So that's where that quick onset comes from. So when you're doing this oral inhaler, you do not get that quick onset. Okay, so people might think, oh, it just didn't do anything for me. Well, it's not going to do the same thing as a vape, an e-cigarettes, heat stick. It's not. Those things use heat, okay, or use thermal to change that nicotine to where it's absorbed through the lining of the lungs. This is still absorbed through the lining of the mouth, so it's still going to have that 5, 6, 7, 8 minute. Really take the hit of nicotine, use that hit, and if you will, that hit is not going to sort of feel the same way. It's going to be very gradual, but really to prevent withdrawal. So you're going to use this, if you will, every 4, 5, 6 hours. Whatever their normal smoking pattern is what they need it. So if they need it every hour, that's fine, but every 2, 3, 4, 5, 6 hours again, and then we're going to taper down slowly. Again, if you thought oral inhaler was underutilized, this is one I bet most of us haven't even seen. Nasal nicotine, if you're going to sort of just list those side effects right there, so you go to the restroom, you're coughing, sneezing, choking, tearing, you do that and you say, gosh, what's wrong? And you say, I'm trying to quit smoking. So yeah, seriously. So imagine that. Oh, man. Oh, and they're tearing. And you're like, dude, what's wrong? I'm quitting smoking. That's not elegant, right? Pharmaceutical elegance, this burns. Okay. So the key, if you ever instruct anyone on this is more like a therapy you would use as a nasal spray that you would use for something like a migraine treatment. This is not Flonase education, all right? So this is not a nasal steroid that you try for, if you will, sinus application and breathe in deeply and try to get this drug up into the nostril. That is not what we want here. We really want to spray and sniff and keep it at the end of the nose, much again like a migraine nasal spray. When you think about something like that, just recognize that coughing, tearing, choking symptom list. People do accommodate to it. People can. This is one of the quicker onset times, but I've honestly only ever used this twice, and both the people did not like it. It just doesn't have a great niche, if you will. But this is one of the products pharmacists are allowed to consider. All right, so little details on dosing. Nothing really, again, I don't think this is something we use a lot. So my summary of NRT, they're more efficacious putting things together. So I think that's important. So I love putting, if you will, patch with either gum or lozenge. During COVID, I'll be honest, when people were wearing masks, I made the mistake more than once of asking which sounds better to you, gum or lozenge? And someone would say something really profound like, dude, I've got no teeth. I'm going to have to use lozenge. And again, it's sort of one of those you can sort of appreciate. It's hard to say which one is going to be right for a patient. But without the proper dentition, then, if you will, lozenge is better for those folks. So picking which one, you can ask them which one they pick, but recognize they do have to have adequate dental work, if you will, to chew gum. So just be thoughtful about that reality. All right. Let's talk about non-nicotine things really, really briefly. I want to do this for completeness, so I want to make sure you guys are good with Zyban. You guys all recognize bupropion is an antidepressant. Does have some sort of reasons not to use it, including seizure disorder, including anorexia, bulimia, other withdrawal things. When we think about this drug, though, what I really want to drive home with this agent, what this really can do is help minimize withdrawal side effects. So if they're going to go into withdrawal, I'm going to send you onto the island and say, gosh, I'm going to put you on the island. You're going to have side effects of quitting smoking, but you're going to hate me. Well, we're going to give you a pill. It's going to help. So whatever those side effects are, let's say they're 10 out of 10. They're horrible. You're irritable. You hated my guts, but I gave you this pill and I hate my guts only like half as much. Okay. So the idea of you're still having withdrawal symptoms, it just helps with minimizing withdrawal symptoms is a way to conceptualize this. So you can use this in combination with NRT all the time. So it's a very nice, reasonable option to use, again, in combination. Main side effect is insomnia. So what I want to sort of recognize here with respect to Zyban, there really are 3 ways we dose bupropion, but to be honest with you, no one does a meter at least 3 times a day. So there's really only 2 ways we dose this, and there's the SR, which is a twice-a-day administration, and there's the XL. I'm a big XL fan, and I'll explain what I do in a second. But by the label, the bupropion, if you're going by the label, what you would do is first one in the morning, and then you would dose the second 150 milligram dose 8 hours after the first. So if your early morning is 8 a.m., 8 hours after the first, you might be 4 p.m. Remember that you want to tell people that differently than BID, right? So you don't want them to take it morning and evening or morning and night. You really want to try to get them to take that, because when you look at the curves at the bottom right, we're really trying to minimize, remember the main side effect is insomnia, we're trying to minimize that trough overnight, which is why I like XL. So when I'm using bupropion as a combination stack, my docs are comfortable with me as a CPP writing for bupropion in the XL form. And that's what I typically do, is use the XL 150. So I don't have to talk about that. And I can just increase to 300 milligrams just by literally having them take it all in the morning again. So 150 once a day, how they're tolerating it, good. Okay, let's increase the dose. I can do that with either SR or XL. Remember, the SR, the Zyban, is 8 hours after the first. Varenicline or Chantix. This is a tough one, and the patient says, how does varenicline work? So varenicline or Chantix, if you will, agonist, antagonist, so use those concepts to a patient without using those words. So it goes to your place in your brain like nicotine, works like nicotine, and then prevents the effect of additional nicotine. So what you're going to notice when you're smoking when you start taking Chantix or varenicline is that those cigarettes just don't hit you the same. You're going to be wondering, why am I spending this money? Because this is just not hitting me the same. Like, I feel like I'm wasting my money. And that's exactly what you want out of this drug. You want that to basically prevent withdrawal by going and hitting the brain where there's nicotine. And then by preventing additional nicotine on top of that from doing any, if you will, downstream dopamine release, they're just not feeling it. And that's really what we want out of the antagonist piece. So that's how we want to explain that to a patient. To me, the key important counseling point here is there's 3 things we do to minimize GI irritation, which is the most common side effect. And they are very simple. We use a starting dose or a taper up pack strategy. We tell them to take it with food, and we split it twice a day. You'll notice at the top of my slide, I put the half-life of this drug in there, and you say, that's a really long half-life. Why do we dose this twice a day? And the answer is to minimize the GI side effect. I think you all appreciate that if we dose something twice a day, split up the side effects, and many times people will tolerate that better. So just recognize varenicline or Chantix. Downstream, it does something very similar that, if you will, nicotine does. So imagine insomnia, abnormal dreams, sleep disturbance. When people say, I was on that Chantix medicine and I just had the weirdest dreams, just go back down the dose. So I use a lot more 0.5 BID than I do the 1 milligram, to be honest with you, because I'm just looking for the benefit. I'm trying to get them some coverage of this medicine to let them taper down and then eventually quit. If I have to taper up because they're not having the success I want, that's fine. I'll just reassess the side effects, but I do not force titrate everybody, because I have many people who quit on 0.5 BID, and I don't have to push it up. So just be thoughtful about that as you work with folks. I put some comments down here on some things that changed. This is sort of old news, if you will, but I think those are there just for completeness. And I'll come back to that concept of mental illness and use in mental illness here in just a moment. Again, this is the official product label dosing for 3 days and twice daily for days 4 through 7. This is the way the starter pack is set up. And then you can quit anytime after when you get to the 1 milligram twice a day. It's the way the instructions read. All right, 2 other agents, just to make super quick comment. One is nortriptyline. In the guideline from 2008, this data is every bit as solid as bupropion data. It's fairly good. What I like about this agent, you guys understand, it's a tricyclic, so it causes sedation. Some of these folks have been having problems sleeping for years. Let's put you on a patch. Let's give you some nortriptyline. Now, if you will, they're getting the nicotine throughout the night. They're getting some nortriptyline to help them sleep. I push that dose up, push it up some more, push it up some more. Next thing you know, they're sleeping much longer than they have in weeks or months or years, and they're really happy. And I do think that this can be really part of a nice regimen. This is, again, not something that you necessarily have access to all the time, but if you collaborate with someone, they say, hey, how can I help you to work with folks? This is something I really like putting in combination with NRT. Don't use a ton of this, and the niche is very simple for this. If someone ever says in front of you, I turn into a witch, I turn into the most evil person ever when I try to quit, tell me more about that. People have told me to go back to smoking because I'm so mad and mean and ugly and nasty. Oh, well, you need some clonidine. So this one, really think about agitation. It really can help with agitation, irritability. And again, you can use this in combination. Many times when we put people on NRT, many times we put on varenicline, they do not get that side effect that they did when they tried to quit cold turkey. So again, I don't really stack this on as often as you might think, but that's really its niche. Many people do really well with just using something like varenicline or NRT that I don't need to stack on clonidine. But the niche is that sort of, I'm just evil whenever I've tried to quit in the past. All right, so Medicaid covers, you got it. Bupropion covers the varenicline, the Chantix, and covers the NRTs and most likely to use, which is patch, gum, and lozenge. Nicotine is not covered in the form of the oral inhaler. As I was going through products, just recognize the one thing about the oral inhaler. It used to be the Nicotrol oral inhaler. Nicorette is now, if you will, the product. So someone should be out there saying Nicotrol was removed from the market, and you would be right. But Nicorette has filled that market space. So Nicorette, if you will, has put an oral inhaler into that marketplace. So just recognize that. Again, not covered, but there is still an oral inhaler in the marketplace. Nicotine nasal spray, again, not a big fan, but he's here for completeness. Again, Medicaid does not cover that. All right. In looking and preparing for this talk, this slide is the only slide I'm putting in here from the most recent guideline, which is the World Health Organization. The WHO put a guideline out literally this year, and you'll see there's 12 points to it. And I want to make a couple comments. I won't go through all of this sort of pictogram, but the one thing is, you surprise, is to incorporate tech. So up near the top, you see, oh, look, it's their phone, and use phone app support and AI. Oh, great. There's a lot of other things in this, but to be honest with you, the World Health Organization really felt like they were saying a lot of the things that we already talked about in other guidelines. Nothing super new, but I do think it was probably not obvious. It was probably obvious you were going to see some about apps and AI in a new guideline, because it's just sort of the trendy thing to do, and they're in here. So it's good. There are many guidelines, so this slide lists a bunch of guidelines out there, and you can look back and sort of find them and say, what do they say? They have different purposes, but with respect to USPSTF, for example, that, yes, we should highly recommend people quit smoking. And what age should we start screening? All adults. Okay, great. When we think about guideline recommendations, pharmacotherapy across all of these guidelines is indicated for all patients using tobacco. So no guideline does something senseless like not say pharmacotherapy is useful. They all say it, and they all recommend for all patients, with a few exceptions. All right, when initiating pharmacotherapy treatment in tobacco adults, this is the American Thoracic Society 2020 document, and I've pulled out only two pieces out of this, so I'm just going to show you, what they are. This is the first slide. Patients should be screened. So the idea of the potential diagnosis of tobacco dependence should be assessed. So the idea of screening people, asking people, great, love it. Diagnosis of tobacco dependence as well as toxic effects, exposure should be incorporated in patients' problem list. You would think, maybe you would, maybe you believe it, that every smoker has tobacco use disorder on their problem list at their clinic at the same level they have hypertension or hyperlipidemia or diabetes, and that is not true. It is not true. Somehow we act like it is not its own diagnosis. So just recognize that we really should emphasize this as a separate, distinct, if you will. So down to number 4, tobacco dependence interventions require long-term follow-up, akin to longitudinal evaluation management of other chronic illnesses. So it should be on the problem list, number 2, and then number 4, yeah, it's going to be on the problem list. The number 3 here is simply encouraging people is insufficient. So say, yeah, you really should quit. And that's just not quite enough. When we think about it, pharmacotherapy to help them stop. Okay, so this is, again, that bullet point that every guideline says, use pharmacotherapy. To drill down then, what they did in this ATS, American Thoracic Society guideline, is said varenicline versus nicotine versus combination therapy. And what they said here, varenicline was superior to nicotine patch, bupropion in achieving continuous long-term, and was associated with fewer adverse events. And when they looked at this, and you start saying, varenicline, bupropion, and you start talking about what can be put with what, varenicline really, as monotherapy, was the most effective. And that's really the key here. I like this statement. I told you I was going to come back to the psychological illness piece. So this psychological illness piece, we've gone from, let's say, pre-2016, where it was like, oh my gosh, varenicline bad. It can cause bad things to people with mental illness. And then we sort of changed the package insert to the point where we're in 2024 here. This document sort of comes out in 2020 and says, hey, if you have depression, you have anxiety, you have schizophrenia, yeah, all these disease states, yeah, varenicline is recommended over a nicotine patch. Now, I know that's not an option for us in our protocol, but varenicline actually is the preferred agent in folks with mental illness per this guideline. That's a really big shift in less than 10 years. That's a really big shift. All right, last guideline here in 2008, sort of the original in 96. This is really just me to touch on it. Next time you guys are going to potentially join a CEN evening, I might be talking about motivational interviewing and counseling. So there's some things out of this 2008 I'm literally just touching. This is the 5 A's. I bet most of you have heard that. If you haven't, there's some resource slides at the end of my deck you can review with a little more detail. In that guideline is also 5 R's. Again, more resources at the end of my slide deck that you can review. Guideline recommendation, how to summarize this. Combination NRT is more effective than single agent NRT. Multiple guidelines say it. And then over on the right, varenicline is better than NRT patch or bupropion. A couple guidelines say varenicline is better. So two sort of buckets of evidence here that are really important to sort of compare, contrast. Imagine 2 is better than 1. Imagine if we do mono. I think varenicline is a more effective agent than what we have as monotherapy, and that's really bottom line. You can put some things together. I don't do a lot of number 1 here, varenicline with a patch, but it is something I've done occasionally. I don't really do number 2 on this, but it's conceivable. Someone might think that's effective. I've done a fair amount bupropion with NRT, both patch and bupropion patch and gum lozenge. So I've done, if you will, triple therapy a lot. Nortriptyline, you've already heard me say, love that with a patch in folks who are not sleeping well. All right, so we're going to talk a little bit about some patient care recommendations. This section probably, if you're like, yeah, I know that. All right, now we might be getting into some areas. It's a little bit more, some details here. So we'll talk about this sort of section here. So selecting doses from cigarettes or e-cigarettes or modern oral nicotine. You're like, modern oral nicotine? We'll get there. All right, so cigarette nicotine containing products. You guys know there's a variety of ways you can get from tobacco. Cigarettes, bottom line, cigarettes wrapped in paper. A mini cigar or a cigar. So in this graphic, you can see this little sort of thing that looks like the size of a cigarette. And Black and Mild in Greensboro, North Carolina is very common. They have little plastic tips. People will switch to those, and they're wrapped in tobacco leaf. And why do they switch from cigarettes to these little cigars? Is very simple. It has to do with tax base, and they're cheaper. So if you're thinking about $10 a pack or $8 a pack for some of their brands, some of these can be much, if you will, more cost effective for the patient to buy, if you will, little mini cigars that are wrapped in tobacco leaf, these cigarillos. And I do think that's something. When someone says they're smoking a cigar, many times our brains go to this thing that looks like the larger picture of the cigar here. And that's really not what people mean when they're smoking that. Typically, they usually mean they're smoking a really mini cigar, and that's, if you will, wrapped in tobacco leaf. I also have pictures of snus on here, a hookah, and then, if you will, a can of the general sort of packets of snus down at the bottom. All right, modern oral nicotine. If you don't know the terms underneath modern oral nicotine, go to a convenience store, actually go into the convenience store and stand in line as if you're going to pay for something. And if you pay for something, you see all the cigarette packs behind the sort of person at the counter. And then you see many, maybe not all, many of the things I listed on this slide right next to them. And what they are packets, they're little packets of nicotine. And this is modern oral nicotine. It's beyond the scope of our time tonight to talk great detail here, but just recognize that there is a range of doses here. And this range you can see on the slide, I've got sort of a 3 milligram packet, and I've got a 6 of the Zyn. You notice I've got spearmint, I've got peppermint. They come in a variety of flavors. Recognize these modern oral nicotines. It's really devoid of a lot of the tobacco containing chemicals. So if you will, they're very, very clean with respect to, if you will, stabilizers, preservatives, color flavorings, if you will. They are very much, clean modern oral nicotine, and they are meant to do pretty much what a gum or lozenge are meant to do: give you nicotine when you want it, when you need it. I'm not going to tell you that I would advocate that you should use this in place of gum or lozenge. I will admit that I have had people come in and they say, can I use this with the patch? And I say, show me what you have. And we talk about the dose. And I say, well, do you have a lot of these? And they say, yeah, my son is using these and he buys them for me. If you want to use these on top of, that's okay. I have done that. I tell them not, I don't really bring it up as a strategy, but if people have that at their access, I will have them consider using that. That is very reasonable. Just like you would use gum or lozenge, they're very similar in how they are delivered. Pretty sure you guys all know about electronic nicotine delivery in the form of a vape or quote unquote e-cig. This is a graphic just to give you sort of range of sort of what is out there and how much does this come. And at the very bottom, that modern oral nicotine may sort of shock you that one of those pouches can contain 12 milligrams nicotine in one of those pouches. So if you thought we sort of had, a caffeine epidemic, where people were taking big doses of caffeine years ago, 5-hour energy, Jolt Cola, whatever, big dose of caffeine, yes, this is sort of a big difference, right? We have 2 milligram and 4 milligram piece, gum and lozenge, and yet we have 6, 8, and 12 milligram nicotine packets. Very different level. You need to be aware they're out there. It's not to say everybody will use them the same way. I've had people come in that they got off their cigarettes, they were vaping, they got off their vape, now they're using modern oral nicotine, and you have to sort of ask them, what's the strength of the packet? How many packets a day are you using? How long do you leave them in? And they might be using more than you think. Okay, so just be thoughtful of that number of milligrams of nicotine. All right, so I'm going to try to walk you through a calculation here. When you think about nicotine intake, we have a range of sort of colors of cigarettes. Earlier I mentioned silver was one of the lower ones. So I'm going to start at the top and just say Marlboro Reds. All right, so Marlboro Reds, everyone's probably heard of those, Red Pack, Cowboy Killer. Okay, great. Got it. Those probably have north of 1 milligram per cigarette. So if you say I'm smoking a pack a day of Marlboro Reds, well, a 21 milligram patch plus some additional PRN nicotine on top of that, gum and lozenge, probably very reasonable. Could you use just a patch and have them cut down? I have absolutely done that. And then bring them back and then add the gum or the lozenge. So you don't always have to do it same day. So just sort of work the plan with the patient, see what their plan is. I want to quit today. If their plan is I want to quit today, then I would absolutely do the 20 milligram patch. On top of that, I would add some PRN, extra milligrams of nicotine in the form of a gum or lozenge, their preference. In that middle ground, that's where you might say, oh, I'm going to use a 14 milligram patch. And maybe those low ones, depending on their quantity, you could potentially even start at what we call step 3 or the 7 milligram patch for someone smoking less than a full 20, if you will 10, 15 of some low nicotine content sort of cigarette, something again that's labeled as like a silver. Okay, so just be thoughtful. We want to sort of think about nicotine content, and again, of what brand can really help you determine what strength patch, and just do the math. Think of, again, the average cigarette, the ones we sort of think of them smoking the most, think around a milligram, but if they start dropping colors on you that are like blues and silvers, you might sort of ask, how many again do you smoke? And maybe if that number is 10, you might not want to do 21 milligram patch there. All right. How do we deal with this with e-cigs and vapes? This is a little bit of a challenge. So what I want to go to here is just think about nicotine straight up first. All right, so calculating nicotine, think 20 and 25% of the nicotine's it's strong versus the salt. And I'm going to get into salt in a second. But greater than 6 milligrams per day, that's what's going to say it in our protocol. Something greater than 6 milligrams, treat them like a pack-a-day smoker, a 21 milligram patch. So this is the protocol, and you see in there in that very first column down there, high nicotine use, you see that 6 to 12 plus. And that's, again, what I want to get back here and say, if just straight up nicotine, think anything more than 6, think of them as a 21 milligram patch. That's where we want to go. The salts, the nicotine salts, this is really sort of the key here, that you sort of say they're not all the same. So there's nicotine and then there's nicotine salts. And the salts have come out, and there's things like Juul. And I think that's really where this sort of e-juice, and you say, well, tell me more about that. I'm going to show you a graphic here in a second. But these salts make them easier to consume, less sort of irritating. And I think if you really think about these salts, they become, if you will, the standard in the marketplace. So that's what these folks are typically using. So down at the bottom here, it's actually an easier conversion. Think every milligram of a nicotine salt. So you have to sort of think through it, like, well, how much are you using? And the patient, if they're filling up the tank, if you will, they'll tell you how long they use X concentration, how many mils of that. And you can just sort of add up the milligrams of the nicotine salt and say, okay, you're using 40 milligrams every 2 days or 20 milligrams a day. And that's like a pack-a-day smoker. And you just sort of do the math with the salt, 1 to 1. So this is the graphic. So again, at the top is the nicotine. So remember, our sort of protocol says anything greater than 6 is going to be high. Right? So nicotine can come in all these concentrations. And the salts, notice down at the bottom, they are much higher. Again, we sort of think of something north of 25 down at the bottom. So that's like a 21 milligram patch and above. Those, again, would be folks that we would probably do a 21 milligram patch plus a PRN nicotine. So if they're using, again, you just want to do the math, but again, think about the salts being about a 4 to 5 fold difference. So that's what this graphic is trying to show you, is just think about multiplying by 4, and you're in the ballpark. This is just an order sheet, and the last sort of comment I want to make to you is you've probably all seen big puffs of smoke, and you all know that fog, and that's the propylene glycol. Just know that you can get high propylene glycol combinations, and you can get ones that are 50-50 with vegetable glycerin. Yeah, if you want to get more fog, then order the high propylene glycol concentration of their vape juice, and that's how they do it. All right, back to the protocol. I think the sort of rest is self-explanatory. So if they're between 3 and 6 of just straight up nicotine, that's going to mean that the moderate range. And if they're sort of lower, then obviously you can go lower. All right, so our straight protocol, combination strongly recommended, and that's really what we want to recommend most of the time. Here's my documentation. This is very much straight out of, if you will, our documents. Nothing really to sort of surprise you here. Just tell me about their previous quit attempts. What have they used previously? Tell me about some of the thoughts. Why do you want to rate them as high, medium, or low? Top 3 here, gum, patch, lozenge, are pretty much what most of us are going to recommend. Again, you can put them in combination. Here's the directions for proper use. So again, you probably only need the top couple here. And then the main side effects, again, with nausea, upset stomach, refluxy type symptoms, dyspepsia, that's really most common with gum and lozenge. Remember, with patch, it's going to most typically be vivid nightmares, dreams, sleep disturbance types of things. Again, you can either lower the dose or take it off at bedtime. Those are the 2 considerations. All right, supportive counseling. I'm wrapping up here. I only have a couple slides on supportive counseling, literally a couple. You heard me say this earlier. What are your thoughts on quitting? So let's say you're dispensing a COPD inhaler. Mr. Jones, I notice you got your pack of cigarettes there, dispensing your Trelegy Ellipta right now. What are your thoughts on quitting those cigarettes? And just let the conversation go from there. Another sort of strategy is, what would it mean to you to quit? Like, would that sort of be something that you're interested in doing? What would it mean to you if you're able to do that? Oh, I'd be able to save money. I mean, people come up with a lot of answers there. My wife wouldn't nag me anymore. There's a lot of things that maybe they come up with, but those are some thoughts that you can get started with. What you want to do is reframe that, whatever they say, and just sort of feed it back to them. Make sure that they hear you say that you were listening. And I think that's important. It's not to say you understand, it's you were listening and that you heard them. And I know it sounds to me like you think this is really challenging. And I would agree it is, but I know you haven't been successful in the past, but that's what we want to do. Help you. Last one. This is a scale question. There's 2 scale questions, importance and confidence. How important is it for you to make a change? So this is, again, 0 to 10. Most people are going to tell you that this is near the top of their scale. Most people who are working with trying to quit are going to be really high. How confident are you willing to make this change? That's a little bit different. Remember, you want to make that doable so that you can quit for a week by the end of the year. is a little different than quit tomorrow. So the concept here of just being thoughtful about what is this confidence rating scale trying to ask them, and is that doable? This is my one slide on resources that you can sort of get from the Quit line. The Quit line's a great resource. They have a lot of things online. I would encourage you to go to that site and look at the resources they have there. I mentioned apps earlier. Here's a couple links to apps that you could use. This is my sort of one slide on healthy goals. You got the bullet point today that where we are right now in adults is just a little over 14. So that's a good number because we're making progress here, folks. I'm going to wrap up here with this opportunity, and I think this is sort of where most of you have joined today, because if you will, there's 100% tobacco-free policy coming out in North Carolina for places that are, if you will, getting Medicaid money. And that's what this slide sort of starts with. So these 100% tobacco-free environment is an essential component to offering evidence-based tobacco use treatment. And if you will, it applies to all of these places, all of these locations. And if you will, this components, if you will, what I get is here on this very last bullet point is the programs that are running these places may not be able to purchase, accept as a donation, or distribute any tobacco products. So pharmacies really have an opportunity to work with patients going to these facilities. Again, I'll let you see this list, and maybe partner with folks to get the product into their hands so they can go to these places and, if you will, do much better at whatever they're there for, because they actually are being treated for their nicotine use disorder, their tobacco use disorder. With that, I'll take questions or extra comments. I have one wrap-up slide and one summary slide to finish. I think I'm right at time, but here's my guiding principles. Pete's 4 Ps, stay positive with this. Be persistent with this, be patient, and remember, progress is key. Any progress is celebrated, and if you keep making progress, we'll get there eventually. And with that, here's my summary slides, one of the most effective things you can do in healthcare. And if you will, what we want to think about as pharmacists is how to adapt therapy, just keep making adjustments to help them keep sort of making progress. And that's really key. So participate with them. Well, let's add some gum. Let's increase the dose of your gum. Let's increase the dose of, yes. Have you worked with your doctor? Do we want to do something different? Do you want to call the doctor and see if they'll do something we talked about today that may not be outside the protocol, but something else might be an option as well. I hope you enjoy helping someone quit, and I'll stop and take questions.
Dr. Koval, we have a couple of questions in the chat. First one was, where do you see GLPs in treatment for addictive disorders, including tobacco?
Great question. I'm waiting more data on that. I wish I sort of had a thought on GLPs or where they fit today, but good question. Today, I think it's still too early to sort of where I'm going to put them, but more to come. I think that's an interesting area for us to look at.
And then how would you manage a patient who got off of cigarettes but is now addicted to modern oral nicotine?
Carefully. It sounds silly to say, but to be honest with you, some of those doses are really big, and I'm really impressed by some of the folks I've worked with. They come in and it's like, so you're using 6 milligram pouches and you use 8 a day, and you're like, oh my goodness, it's like that's north of 2 packs a day. When you think about that and you say, gosh, how am I going to get them down? You really have to just think about, you can do that with the pouches because they've got a lot of different strengths, but you just have to walk them through a quantity taper. So I think it's actually relatively straightforward. Is you just have to start saying, well, what do you think? Can you decrease 2, and have them either by delay, meaning put more time, or particular trigger, meaning that you're not going to put a pouch in after lunch, like pick a trigger and get rid of that trigger and don't put a pouch in then. I think those are types of things you can do for the modern oral nicotine, but I think you can use that to taper down. I would not oppose using something like a patch so that they are not, if you will, linking tobacco withdrawal. So you can put a patch on board and that could help as well.
How do you know if an e-cig has nicotine or nicotine salts?
Yes, good question. Nicotine versus nicotine salts. As a general rule, read the label, but the dosing will probably give it away. You're going to see the doses of straight up nicotine be something single digit-ish. You're going to see the dosing typically of the salts be something significantly more. read the label, but if you will buy product, you'll be able to tell which one has a nicotine salt in it, and start reading components. If you start seeing benzoic acid, that's the salt, if you will. If you start seeing that as the component, then think salt, and that is the much more common one out there.
I think one of our attendees had asked, what resources do we have for teenagers addicted to either smoking or vaping, as most tobacco cessation products with nicotine are for 21 years of age and up. And there was a link put in for the Be Vape Free Catch My Breath campaign that was added in there. Do you have any additional resources?
No, I think that part of it's really tricky with treating folks under 18, parents who's involved. I don't have any specific resource. I do think there's probably some, sort of buy-in there that you got to get sort of buy-in from the family, but you can get that. And to be honest with you, there's nothing about the products we use that really would be inappropriate. Does that make sense? Like, you could use the things, but you would sort of have to tell them you're using it out of off-label, but it absolutely makes sense that they should be able to use effectively by an adolescent, a 17, 18-year-old.
Super. And Amy, I don't want to forget your question. It says, there's one that says, I've had difficulty billing North Carolina Medicaid for a tobacco cessation consultation. Is there a step-by-step guide for billing Medicaid for these services? So as most of you know, this is a great segue into ending our evening together, because I just want to remind everyone that this was part one of a 3-part series that we are going to continue to provide throughout the rest of the year. So in November, our Sunday evening series, I think if I'm not mistaken, it's probably going to be November 17th. Don't quote me on that, but I believe that's the date. We'll also dovetail into what Dr. Koval has spoken about tonight, where we'll cover more around the motivational interviewing component, service model development, as it relates to pharmacists providing nicotine cessation services. And so just want to remind you that that will happen. And then coming again in December, we will start to address Medicaid billing. So I don't want to put you off, Amy. It's kind of a loaded question because it depends on exactly who you're trying to bill. Is your patient a direct Medicaid recipient? Are they a member of a Medicaid MCO? Are they a member of a Medicaid tailored plan? All has something to do with the billing component behind it. If you will, I'm going to put my information, my email in the chat. If you would like to reach out to me independently, I can try to help walk you through a process for billing, depending on the actual patient that you're talking about, depending on what Medicaid program or plan that they are part of. But we will also be covering in broad detail in December the Medicaid billing component piece to NRT. So I hope, oh, I didn't hit that. There's my email address if you'd like to reach out to me. Be glad to help you with that piece. We will definitely, again, be doing more of this even after the first of the year, as we start to learn more and more about Medicaid billing and having new and different opportunities that are coming down the pipeline for pharmacists to get paid for certain services. So hope you will stay tuned for that. Again, I'd like to thank everyone for attending tonight, and especially Dr. Koval for his insights. Always a pleasure to listen to what he has to say. It's so down to earth and makes so much sense to me. Love to have him and so appreciate